we talk about this a lot. I've seen your comments, we see the feedback, and we wanted to make sure that in this conversation, we not only address some of the questions that you are able to send in, but also Dr. Ungar will give us an amazing information. So, thank you so much for joining us tonight. This will be recorded just so everyone knows, and it will be available to watch on our YouTube page. But again, thank you so much for spending a Friday night with us. And I'm going to kick it on over to Dr. Unger.
Thank you very much. Thank you for that kind introduction. Really a pleasure to be here today to talk about some emerging treatments for scarring alopecia. We'll kind of dig into some aspects that I think are worth thinking about, discussing. It's not intended to be fully comprehensive. Certainly many details will be kind of left out, but hopefully we'll give an overview and provide some updates on where things stand in the field. Here are my disclosures. So before we discuss new treatments, I thought it would be useful to think about how we assess if treatments work and how we think about whether something's beneficial, how we put together the scientific evidence, studies, and what they mean. Because at the end of the day, there are going to be different kinds of studies, different treatments, they're designed differently. And so what do we make of them? And so that is the key, of course, is to perform studies. And there are different types of studies or different components that may be helpful. So certainly clinical studies that look at different aspects of a disease. So when we're talking about scarring alopecia, many people, of course, have symptoms, itching, pain, stinging, burning. One of the clinical aspects we look at is stabilization. So if we stop the hair loss that may be ongoing prior to treatment, and then, in an ideal world, how much hair regrowth there is as well. Another important aspect about studies is, in many cases, is to do mechanistic studies where we look at the underlying biology, often through scalp biopsies, in some cases, other kinds of tissue samples, where we then profile and look at the underlying processes with the disease itself, often before and after treatment, to help us understand what's happening. And, ultimately with the goal of identifying treatments that may work, and in many cases, treatment targets, where we say, potentially we can intervene and treat a certain aspect of the disease that we've learned about through these mechanistic studies. There are different kinds of studies that provide us different levels of confidence in interpreting how well a treatment works and if the study really is telling us what we think it does. And so this is kind of just a very broad overview where large randomized controlled trials with clear results are kind of the highest level of evidence, the strongest support that we have for treatment. And that goes all the way down to case series, or in some cases, case reports, where there are sort of more anecdotal evidence. And this is really the category where we think about, maybe you've heard of a colleague or a friend who was treated with XYZ treatment and, oh, she did great. Well, that would fall under this kind of category, and that gives us the least confidence it works. And the reason for that is that's essentially anecdotes. So, it's hard to know from 1-2 people if that's going to really translate and be applicable to other circumstances, especially since when we treat one person, we have no way of knowing what would have happened with a different treatment. So how do we really compare? Now, with that said, case series and case reports often are excellent for prompting studies. Maybe 1 or 2 patients respond very well to a treatment. We say, hey, let's study that in more depth. They certainly need to be taken with a large grain of salt for the reasons I mentioned. And often case series can be strengthened where we look at biological or mechanistic components. So even if it's a few patients, if we start digging into the biology, then that can give us more support. Or if that case series developed, we tried treating patients because there was a really strong rationale to begin with, and we can say, we hypothesized that this treatment would work. Here are some people in which it did, and that gives support for other studies as well. And so the reason I'm starting off with this is I think it's important to have an idea of how much confidence we have in the treatments that exist that are emerging, and what more is needed ultimately for us to get to a point where treatments catch up to many other conditions. The other aspect that I think is worth discussing before we dive in is to understand, at least kind of big picture, what is happening in the disease. So that way we can think about what the treatments ultimately are targeting and what they're trying to do. And so this was a schematic from a few years ago that I think is useful from a big picture perspective to understand what's happening with the disease. So there's some component of risk factors, whether it's genetic, environmental, that's probably not probably, it's different in different versions of scarring alopecia. And that's still a work in progress to really characterize better. But for whatever reason, there are these predisposing factors and some external factors that lead to what's called immune privilege collapse. Now, in normal, healthy scalp and hair follicles, the immune system doesn't attack the hair follicles. It's kind of protected, and that's that immune privilege. And then for whatever reason, there's a shift where the immune system now says that is something that's worth attacking and leads to this process. Now, with these scarring alopecias, in particular, the pathology, the process is happening what's called the bulge region of the hair follicle. And that's where the stem cells are that help for the hair follicle to recover when there's there's an attack. And if those stem cells are destroyed along with the hair follicle, then that can lead to permanent issues. And so that inflammatory process kind of starts things rolling. And then over time, there's fibrosis, scarring, and ultimately leading to kind of an irreversible process where we're no longer able to regrow hair. Now, when you think about this schematic, hopefully you can identify that there are different steps along the way where, in theory, we could stop the next step from happening. But practically speaking, we're best positioned currently to really attack this part of it, which is the inflammation. We don't yet have treatments that stop immune privilege collapse. When we get to the scarring, there are certain challenges, that fibrosis, but the inflammation is something that we may be able to address. And probably this is, obvious to many people, but early treatment is key because we need to get that inflammation before it leads to the next steps where that scarring develops. Fortunately, in recent years, there have been more studies that have been performed to understand that underlying disease process and not just identify that there is inflammation, but also kind of tease out many of the details of the inflammatory processes, which allow us, again, in principle, to be more specific about how we are targeting and stopping the inflammation. The primary inflammatory cells in scarring alopecia are T cells. And within that, the primary T cell pathway, as far as we understand, is what's called Th1. And so there's increased Th1 inflammation. And so if we are kind of fundamentally trying to stop that process, we need to lower that. And so now, again, from a high level perspective, we have a path forward to say, how can we reduce that to stop the process? Now, to understand what kind of new emerging treatments have some promise, it's useful to start with what the current treatments are. And we'll start off with CCCA here, because a few years ago, there was an expert consensus that discussed what treatments were recommended by a number of experts. And the things we'll see that are a strong recommendation, 3/4 at least of experts who treat scarring alopecias agreed are treatments. So there are high potency topical corticosteroids, intralesional steroid injections, topical minoxidil or oral minoxidil, typically as an adjunct treatment, not as the primary treatment, oral doxycycline, oral antibiotics for potentially a number of months, with the idea that you might lower the dose if symptoms improve and the hair loss stabilizes. Hair transplantation only if no active inflammation. Limited information on the use of platelet-rich plasma or fibrin. Actually, not quite as much agreement for the use of hydroxychloroquine, although that's traditionally been used in many cases. And then there are some other treatments that are used sometimes. The first three listed are broad systemic immune-lowering medication that are associated with many risks and side effects. and some other topical non-steroidal anti-inflammatories that have played a role. When we look at FFA, this was a study that was published only a few years ago that did a broad look at treatments studies that were done. And one thing that I'm highlighting here, just to show you the state of what we understand about this, is at that time, no randomized trials were found. Almost all of these were retrospective cohort studies where people look backwards and say, here's how people were treated. So not necessarily even done initially as a research kind of approach, but normal clinical care, and then looking back to say, okay, what sense can we make of that? And so you'll see a list here of treatments that overlaps quite a bit with CCCA, topical and intralesional steroids, topical calcineurin inhibitors, non-steroidal anti-inflammatory topical, hydroxychloroquine, doxycycline. In the case of FFA, finasteride and dutasteride, retinoids like isotretinoin and acitretin, pioglitazone, some systemic immune-lowering medications like methotrexate, prednisone, mycophenolate, and topical minoxidil. So somewhat of a core kind of overlap, and none of these had very rigorous studies. It's more of an issue of looking back and saying, let's see if we can characterize how people did. This was one study, looking at over 300 patients. This was done in the Netherlands, so maybe a different approach overseas with LPP and FFA over the course of 6 years. And you'll see pretty much similar treatments. This kind of core, steroids, other topical or systemic immunosuppressive medications, minoxidil, antibiotics, and so on. Now, importantly, when they looked at the treatment responses, we see here what they're describing, as responses as generally, unfortunately, kind of underwhelming. And we know that's the case because we need new treatments. If we had amazing treatments right now, we wouldn't really be giving this talk. So hydroxychloroquine, a good response, kind of relatively low in both LPP and FFA, and ultimately, we're targeting good responses, great responses, not just minimal responses. Methotrexate, pretty low rates, and cyclosporin, those are two systemic immunosuppressive medications. Retinoids, none of these really with overwhelming success. And this was all retrospective. And this is not even addressing the potentially numerous side effects associated with these treatments. There was a relatively recently published study looking at a large database analysis of treatments for LPP in the US. And, surprise, surprise, we're seeing really the same treatments. And this was as recently as 2020, steroids, antibiotics, hydroxychloroquine, and so on. Now, I would like to take a moment also to look at oral low-dose naltrexone to kind of illustrate some of the caution that's needed with studies, because low-dose naltrexone has been published in certain, small case series or case reports as potentially being beneficial, which prompted larger studies. And that's really how this should work. We use kind of initial ideas to then lead to larger studies. So this was one study that was an uncontrolled open label prospective study. So patients knew what they were getting. There was no comparison. So it's hard to know in a case like this, like what would have happened in general. But nevertheless, patients received low dose of oral naltrexone for 12 months. Relatively small study, but with 26 completing it. This was the overall look. So in terms of itching, burning, pain, a little underwhelming. When we look at the assessment of erythema, redness, and scale, that does look like some improvement. And certainly from the physician assessment evaluating patients, it does seem like this helped. And so that, again, is promising. And it may be easy to take a look at this study and say, great, we have a new treatment. But this is another study that was a randomized controlled blinded trial in LPP, same dose, although this one was for 6 months. And in this study, everyone was using topical clobetasol nightly, except that some people also got naltrexone. And one of the things that I want to highlight here is when we compare this to the other one, the study duration was different, 6 months versus 12 months, different potential adjunctive treatments or comparisons. When we are treating scarring alopecias, where we know that early treatment is important. There's a question of, how much time can we give a placebo, where we know that time is hair, where people are not getting treated. So there are ethical considerations, makes it very difficult. And so we do the best that we can to navigate things and kind of factor in these considerations into how we interpret how effective a treatment is. And then, so in any case, this study, some people were treated with a topical steroid, a strong topical steroid, other people with a strong topical steroid plus naltrexone. And so at the end, relatively small numbers, but what we see here in this graph, where the solid line is the naltrexone and the placebo is the dotted line, over the course of 6 months, not really much of a difference. So this doesn't seem to improve things. Now, everyone improved to some extent, but the fact that the placebo group that were not receiving naltrexone improved really suggests that the effects and the improvement were from the topical steroids. And in fact, looking at different kind of components of the disease, the only thing that was maybe a little significant was the scalp redness. None of the other factors were, and the overall view did not really suggest that this is an effective treatment. So that kind of raises the question, does oral low-dose naltrexone work? And the reality is it is still difficult to tell from the available studies. And I listed two, perhaps two of the bigger ones, and those don't necessarily provide evidence that it works, but maybe we need larger studies to evaluate it. Maybe we need longer studies. Hair loss is a long-term process, and maybe 6 or even 12 months is not enough for this particular medication to work. Perhaps studies with biomarkers might help. If we do biopsies, evaluate the changes on a biological level, we may not yet see that from a clinical perspective where we're looking at what's happening or patients are reporting the way they feel, but we may still see changes in the underlying disease process that might kind of give us more confidence to pursue further studies. So, so far, not necessarily supported by evidence, but the jury's still out to some extent. So let's talk about some additional emerging treatments. So I'll start off with metformin, which is a treatment that was recently published in a case series of 12 patients with CCCA. Now, metformin is a treatment that's often used to treat diabetes, so not an anti-inflammatory medication per se, or at least not kind of centrally the case. And in this study, everyone at least was stable or worsening, so they weren't on a trajectory towards improvement, and then they were started on oral metformin. 4 of the patients provided biopsies, and as I mentioned, often having the biopsies, the mechanistic studies that we look at biomarkers can be extremely helpful to understand what's happening in smaller numbers of patients. And so among these 12 patients, 8 experienced noticeable improvement in clinical symptoms, pain, pruritus, inflammation, and so on. 2 had worsening symptoms. We certainly don't expect any one treatment to be universally effective. And 6 patients demonstrated clinical evidence of hair regrowth for at least 6 months. And so here are some of the results that were published in this study of patient responses. Now, I mentioned the biopsies, and this is I think, very interesting for patients. So, so a relatively small sample, but because these mechanistic studies are very fine-tuned, we can still get a lot of information for it. And so in the blue is the biopsy before treatment, and in the kind of orange or yellow-orange is the results after treatment. And so that change is helping to tell us what's happening with the treatment. And so the boxes that I've highlighted here are different inflammatory pathways. And there's kind of some suggestion that a number of them are being decreased at least a bit. But what's very interesting is these markers of essentially some of that fibrosing process went down quite a bit from before to after treatment. So that's something we would want to see. And these are keratin-associated proteins. So proteins that are involved in the actual hair shaft growth increased a lot. Again, so exactly what we would want to see where that is evidence of hair regrowth. So, in conclusion with metformin from that study, it's a promising treatment. We certainly will need larger trials, potentially randomized trials, but the initial results, particularly with that mechanistic component, are promising and really warrant additional investigation. particularly since this is not directly an inflammatory treatment, but potentially targeting some of the other aspects of the disease. So what about PRP, or platelet-rich plasma? So here was one kind of large study looking at patients with FFA. Some of them were received the platelet-rich and growth factors, which is a version of PRP, and others did not. And so what did the results show? So for one thing, we can see that the control group of 57 patients, the PRP group 61, had a number of different other treatments, which makes it hard to tease out the exact effects of the PRP. But if they do better, even though they're receiving similar treatments, that's certainly encouraging. So again, a number of different kinds of treatment, topical steroids, topical minoxidil, and so on. And another aspect about this is that the patients received a number of different sessions of treatment, anywhere from 6 to 26, again, making it a little hard to interpret just how much this is doing, because if patients require more sessions and they didn't get enough, we don't know if that's because they didn't get enough treatment, so there are a lot of confounding factors. And that's one of the challenges often with retrospective series, is that things are not consistent, because in real life, treatments are not going to be consistent, and we're looking back at real life treatments subsequently. And so the results here show, a hint of maybe some increase or improvement in the extent of alopecia. That's from the hair perspective. Inflammation levels went down overall. Hard to say a major difference between the groups there. The disease activity score overall, again, showing a little bit of improvement. So, I think in conclusion, this needs further investigation. The preliminary results here are, potentially promising, a little hint of improvement, at least in certain aspects of the disease. But the study, had a lot of confounding factors, a lot of other treatments. Potentially future studies would benefit from a more standard treatment protocol, so that we know, if you do X number of sessions of PRP, this is what it shows. And I always have a kind of bias towards using biomarkers for all the reasons that I've mentioned. So perhaps in the future, taking scalp biopsies before and after treatment, analyzing them and seeing what the PRP is doing on a molecular level. The next emerging treatments that are, I think, are very exciting are topical JAK inhibitors. JAK inhibitors being anti-inflammatory medications, and these, as the name suggests, are topically applied. So this was one study that looked at 41 patients with either LPP, FFA, or kind of overlap, or both. And they were treated with topical tofacitinib for at least 3 months, many of them for longer. And so we can see here kind of some characteristics of what happened in the study. Some people received only tofacitinib, about a quarter of people. Others received tofacitinib in addition to other treatments. The average duration was 9 months of treatment. And of those 3/4 who received other treatments, we see here what those were. So, a majority of people oral minoxidil, a quarter, give or take, hydroxychloroquine, and so on. And the results here are quite intriguing. So, when we look at the disease score for LPP here, and that's true of all the patients receiving it, also the patients receiving only the treatment and nothing else, we see a significant improvement in that clinical score before and after treatment. A pretty good portion of complete responders, and then a majority of the people who weren't complete responders had some partial response. So it's actually low rates of non-responders in this study, which is encouraging. There was a different retrospective series looking in kind of a similar population of LPP, FFA, or kind of overlap or both, using a different JAK inhibitor, this one ruxolitinib. Similarly, for at least 3 months, the mean treatment was, almost 9 months. And we see here that, perhaps a larger proportion of patients in this study were receiving other treatments as well. But what we see here is that across the board, FFA, LPP, or both, we're seeing, pretty nice proportion of people getting at least 75% improvement, almost 50% getting intermediate improvement, 25 to 75%, and only one third not experiencing at least a 25% reduction. And I think importantly here, we're talking about very small numbers, but we see kind of a signal that the frequency of use makes a difference. So the responses with twice daily look better than the responses with daily or every other day, suggesting that potentially the dosing frequency makes a difference. Now, these are all very preliminary numbers, but this provides potential rationale and springboard for larger studies. So I think in conclusion, this is a promising treatment approach. We'll need some version of randomized trials or kind of better controlled trials that are prospective, where we characterize from the beginning, treat patients, and see how they do. But hopefully that is coming. I expect it to be, and may provide a treatment approach that will benefit patients with a topical anti-inflammatory. And then the last category of emerging treatments that I want to highlight are oral JAK inhibitors. So these are pills typically taken once a day. And so this was one study looking at patients with CCCA and LPP and FFA. The treatment here was brepocitinib, which is a JAK1 TYK2 inhibitor. This is not approved for any dermatologic indications currently. The study had some placebo randomization for 24 weeks, and then everyone subsequently got the medication. So some people, 75% received 48 weeks of treatment, and then that last 25% placebo for the first half, and then received the treatment for the second half. And in this study, the primary endpoint was levels of CCL5. So it's a biomarker taken from biopsies, which is part of that Th1 pathway that I mentioned. And so, that's the core of the inflammatory process that we're targeting. This was an attempt to see, are we actually achieving that goal? And so what we can see here is at 24 weeks, the placebo group did not have any improvement. That would be a decrease below the line, which is what we do see with brepocitinib, that decrease in CCL5 levels, showing that there's some reduction in that Th1 inflammation. And then the fibrosis didn't necessarily significantly decrease with the brepocitinib group, but in the placebo group, it was worsening. So perhaps, a little hard to conclude for sure, but perhaps it was at least interrupting some of the worsening fibrosis. When we look at the clinical scores for these patients, we see that nice trend down, which is that improvement. And that solid red line is the patients treated with brepocitinib over the 48 weeks. And we see kind of over time, there's that nice improvement. And also importantly, when people were switched from a placebo to the brepocitinib, which is in that lighter pink, a nice dramatic improvement. So this was for LPP. We see maybe a little more modest results in FFA, but that brepocitinib treated group over 48 weeks had improvement. So that decrease down the graph. In the placebo group, really no improvement, maybe a little worsening. That subsequently looks like it's starting to improve. That's in that pink again, going down. And so maybe hints again towards that improvement. And in CCCA patients, we see initially maybe not as much of improvement, but over time that brepocitinib group improved quite a bit. And the placebo group similarly didn't really have improvement, but then when switched to brepocitinib, did have improvement. So, a promising treatment, an oral immunosuppressive treatment here targeting that inflammation. And here's some examples from that study in terms of the clinical responses. And then lastly, this is kind of hot off the press, a study that was presented last week at the European Academy meeting. So this is new data presented about a randomized controlled trial that's a typo. This is an open label trial, so it was not randomized in CCCA patients, 20 patients, LPP patients, and FFA. This is using ritlecitinib, which is an oral JAK3 TEC inhibitor, and that is approved for the treatment of alopecia areata in the US. So this was an open label treatment study, as I mentioned, not a randomized control. For 24 weeks as the primary endpoint, but everyone was treated for 48 weeks. I will note that the dose in this study was initially 200 milligrams, then daily for 100 milligrams. That's a higher dose than is approved currently for alopecia areata, which is 50 milligrams daily. And we will see here that in LPP, we see a nice decrease over time in the disease score over the course of the 48 weeks, and then actually a little worsening after the end of treatment at 48 weeks. In FFA, again, we see that nice consistent decrease over time in the FFA disease severity score. And similarly, in the CCCA disease severity score, we see that the disease severity reduction over time. And so again, these are promising treatments. Certainly need additional studies. These are initial, kind of more, these are rigorous studies, but larger numbers, future studies are needed, additional characterization of the biologic underlying mechanisms, but again, very promising. And so with that, I would like to thank you for your attention. Hopefully this provides a glimpse of some of the avenues that are under investigation that may lead to new treatments that are ultimately approved. That's certainly the goal for this. As we discussed at the beginning, looking at the overview of the disease pathology, it's a complicated disease or set of diseases that have multiple factors or multiple time points that ultimately we hope to be able to intervene and help both stop hair loss and ultimately, potentially regrow hair in very theoretical terms. And so this is really just the beginning. As you saw earlier, it's only recently that these more rigorous studies are being done. And fortunately, scarring alopecias are getting more attention now and resources with new treatments available for other conditions that are being used to study in this condition. And so I really am optimistic that in the upcoming years, the talk that I just gave about emerging treatments will be much more expansive. And so with that in mind, I'm happy to take questions.
Yay. Well, Dr. Ungar, thank you so much for that amazing presentation. As we just said, we are going to hop on over to the questions. I know that we have a good amount. So the first question from the group is, what is the percentage of JAK inhibitors in topicals?
It's a good question. And the answer is that it can vary, and it varies from JAK inhibitor to JAK inhibitor. In the two studies that I mentioned, one was tofacitinib, which is actually not approved for anything in a topical form. That typically needs to be made by a compounding pharmacy. It's only approved in an oral form. So that can vary based on what percentage is done. Often it's 2%, but that's not the only concentration or percentage that's there. With topical ruxolitinib, which has the brand name of Opzelura, which is approved to treat atopic dermatitis and vitiligo, the percentage is 1.5%. And additional treatments in the future with topical JAK inhibitors may have different numbers as well. But that's what's available so far.
Great. And since we're talking about JAK inhibitors, another question that the group had is it beneficial to use topical JAK inhibitors if you're already taking an oral JAK inhibitor?
Yeah, so that's also a great question. One comment I will make is, unfortunately, it's difficult, in a setting like this to have a lot of confidence in answering individual situations because people are very different and the circumstances are different, clinical picture, treatment history, all these factors make a difference in what the best course of action is, for you as an individual. Now, oral JAK inhibitors have anti-inflammatory effects. To some extent, the amount of inflammation that's reduced from oral JAK inhibitors is limited by the dose. So as a general rule, you can imagine the higher dose you take, the more anti-inflammatory effect within reason. But we also have to weigh that against potential safety considerations, risks, adverse events. And so in some circumstances, people may benefit from using a topical JAK inhibitor in addition to an oral JAK inhibitor because that topical is adding some additional anti-inflammatory activity on top of what's happening with the oral JAK inhibitor. But it's hard to say for sure, but in many cases that may be the case.
Hey, thank you so much. Okay, another question that I'm seeing not only from the chat, but it was also asked a good amount in our questions is about, and apologies to everyone if I butcher this, folliculitis delca delvans.
Folliculitis decalvans. Yep.
Yes, there we go. And that is why you are the doctor and I am not. Okay, so there were a good amount of questions regarding FD. And one of the questions was, what are the most effective current treatments, and are there any emerging treatments specifically for FD?
That's a great question. So when we talk about scarring alopecia, as I think many people here know, there are a number of different clinical entities that fall under that umbrella. Um, I discussed the three most common ones that are all considered to be primary lymphocytic, the lymphocytes, those T cells that are playing the role, but they're not the only versions. As we know, unfortunately, scarring alopecia in terms of our understanding and treatments is lagging behind many other conditions in dermatology and in medicine. Um, I would say that in the umbrella of scarring alopecias, folliculitis decalvans is even behind the curve compared to the ones that I talked about today. So, in short, there are not really yet very significant or great studies looking at emerging treatments. So, we're primarily focused, or we primarily have available really case series, essentially. It may not be exclusively the case, but that's the primary. There are certain treatments for other conditions, like, for example, TNF inhibitors that are used in psoriasis, rheumatoid arthritis, inflammatory bowel disease, that have some suggestion that may be effective for folliculitis decalvans. It may be the case that some of the treatments we're talking about for the conditions I spoke about today, oral JAK inhibitors and so on, may be a benefit too. But I think that we're still behind the curve, and hopefully soon we'll be able to talk about emerging therapies for that in a similar vein that we do for these that I mentioned today.
Great. Well, thank you so much for that. I know that there is so much research that still needs to be done with scarring alopecia, but I know that we all appreciate any sort of additional information. Okay, our next question is, do you have any information around laser therapy or ultraviolet light treatment? And if so, how do you feel about it?
Also a great question, and a common one that patients have. So one of the um, aspects about understanding, if treatments work is something hopefully that I got across during the talk, which is that in order to say if a treatment works or not, we need to have the kind of scientific evidence and the studies to give us that indication. For many treatments that are considered in some cases, that may just not be there. And that doesn't mean a treatment doesn't work. It just means that we're not really in a position to say whether it works or not with a high degree of confidence, or really any confidence at all. I would say right now, there are not good studies that certainly that I'm aware of that demonstrate that the laser treatments necessarily help. I would say to a large extent that's true of UV lasers as well that are anti-inflammatory. I do know that many people will use some of those UV lasers to treat some of these conditions in addition to other approaches, and again, anecdotally have success. Um, but as I mentioned at the beginning, we need to be very cautious about putting too much stock in anecdotal information. So the bottom line is that those may help, and in some cases, I'm sure there are people who have benefited from them. But we need to do more work to have the ability to answer that question more confidently.
Okay. Our next question, we've actually gotten a few questions in the chat and also questions that were sent in around Opzelura cream. and kind of using that, and also to the best approach to using Opsilura or best case scenarios while monitoring symptoms like increased inflammation.
Sorry, I may have missed that. Do you mind repeating the first part of that?
Of course. So a good amount of our audience has been asking questions about Opsilera cream, and
Mhm.
more questions around, when is the best to use it, and also how do I approach using it while monitoring other side effects?
Got it. Yeah, so it's a good question, and again, there's never going to be a right answer for everyone. So I'm speaking in generally broad terms. The goal from an anti-inflammatory perspective, and that is true of any treatment, is really to reduce the inflammation. And there are different ways of assessing that, whether it's symptomatic, whether it is your dermatologist evaluating your scalp to see signs of inflammation. And the goal is one way or another to reduce that inflammation. There's no one approach to that. So there may be some people for whom a topical JAK inhibitor like Opsilura is a good first step. It may be the case for some people that that is an addition if another treatment's not working or switching. So it's hard to know for sure. In the clinical trials and real world evidence that we have for atopic dermatitis and vitiligo, which are the diseases that Opsilura is approved for, it seems to be quite safe. So in general, there's not a high degree of monitoring that's needed from a safety perspective, but every disease is different and people are different. So, hopefully there will be studies in the future that answer that question more specific to this circumstance.
Great. Okay, and our next question is back in the JAK inhibitors overall realm, since I know that we all have a good amount of questions about JAK inhibitors as an overall whole. So, one of the biggest questions that I'm getting from the group is, what are the effects of JAK inhibitors on the immune system? And again, I know that we're talking all generally, but if there's any sort of additional tips or information.
It is a really great question, and it's one that, as a medical community, we continue to try to understand better to be able to answer more specifically. Oral JAK inhibitors are immunosuppressive, meaning that they do lower the immune system. Now, the immune system is quite broad and complicated. There are many, many different components, and JAK inhibitors block specific components. There are JAK signaling, the JAKs that get blocked, that are also involved in other processes in the body, like blood cells, and various aspects about cardiovascular functioning. And so when we think about the risks of oral JAK inhibitors, we kind of put that all together. The FDA has placed a boxed warning on all JAK inhibitors with some potential serious risks, including serious infections. And I think that it's important to recognize that when someone takes an oral JAK inhibitor, to some extent or another, you are lowering the immune system. Now, how much that actually plays out in terms of infections that are increased that you actually experience remains to be seen. Thus far, in most of the studies in using oral JAK inhibitors in different dermatologic conditions, there were low rates of serious infections. But I do think it's important to acknowledge that it's not zero, and that's a kind of a risk benefit discussion between the patient and the physician to decide is that the right treatment or is that a right approach on an individual basis. So the answer is it's a little hard to tell, but it is immunosuppressive, and how much that shows up with serious infections is still a work in progress to understand.
Great. Well, we appreciate any sort of additional insight. But everyone, I know that we have endless questions for Dr. Unger, of course, because we could definitely be here all night. But Dr. Ungar, we just want to say thank you so much on behalf of the Scarring Alopecia Foundation for not only giving us that amazing presentation, but also to answering so many of the amazing questions in the chat. Again, I know that our audience overall, we have endless questions, but we will have more webinars. We will have more opportunities to ask more questions. So stay tuned, everyone. Just so you know, if you showed up late, this webinar will be on our YouTube as of October 1st. So also I will send out an additional email reminding everybody. But again, I just want to say just a special thank you to Dr. Unger. Thank you so much for spending your Friday night with us.
Thank you for inviting me to speak and having the opportunity to speak about some of the what I really do consider to be exciting new developments. We certainly collectively have a lot of work to do, but I think there's a lot more reason for hope now than there was even a few years ago. And having the chance to share some of that, I really appreciate that. Thank you everyone for spending your Friday evening with me. And hopefully next time we have this talk in the future, there'll be more and more exciting treatments to discuss.
Exactly. Yay. Well, thank you so much, everyone. Thank you so much, Dr. Unger. And I hope everyone has a great Friday night and a great evening.
Take care, everyone.
Bye-bye.
How do I get out of this?
Oh, you actually just press the end. I will actually end it for all of us. Have a great evening.